Let's discuss the blood and hematology under certain headings. You know, the blood is a liquid connective tissue composed of the liquid called as plasma and the cells, the formed elements of blood. In any unit quantity of blood, plasma is roughly about 55% and cellular component is about 45%. The cells, RBCs, WBCs and thrombocytes. So we will discuss the blood under 4 sections. Plasma, mainly we will see the plasma proteins, then the RBCs, erythropoiesis and the factors influencing erythropoiesis, then WBCs, formation of WBCs and their functions, platelets and the formation of platelet plug, and then the clotting mechanisms. Finally, we will discuss about the blood groups. Let's start with the first small topic, the plasma proteins. The normal plasma protein concentration is about 7 to 8 grams per cent. And there are 3 important proteins in the plasma: the albumin, the globulins, and the fibrinogen. All of these plasma proteins are synthesized in the liver except the gamma globulins. Apart from the gamma type of globulins, all others are synthesized in the liver. In fact, there is something called as albumin to globulin ratio. The normal albumin globulin ratio is about 1.7 to 2 is to 1, and this ratio is said to be reversed in severe liver diseases. This is of the liver parenchyma, and this ratio is reversed. So liver synthesizes most of these plasma proteins. The normal levels: albumin 4 to 4.5 grams per cent, globulins 2 to 2.5 grams per cent, and fibrinogen 0.2 to 0.4 gram per cent. There is one more, prothrombin, very less amount, 0.2 to 0.4 grams per cent. But mainly we have albumin, globulins and fibrinogen. What are their functions? Albumin exerts the plasma colloid oncotic pressure. Plasma colloid osmotic pressure, globulins. There are various types of globulins: alpha globulins, beta globulins, gamma globulins. The alpha and beta globulins, they are mainly the transport proteins. Ceruloplasmin for the transport of copper, haptoglobin for the transport of hemoglobin when it has come into the plasma, and or transferrin for the transport of iron. These are the alpha and beta globulins. Gamma globulins are the antibodies. Immunoglobulins are the gamma globulin type. Antibodies formed by the B lymphocyte, they are the gamma globulins. And fibrinogen, the third plasma protein, is involved in the blood clotting. Of course, it forms fibrin, and fibrin threads form the clot. So we'll talk about it much in detail later on when we discuss the clotting mechanisms. Now let's see the cellular components one by one. So starting with RBCs. Well, RBCs are 8 micron diameter cells, biconcave shaped, non-motile, non-nucleated, and they lack most of the cell organelles which other normal cells have. Basically, the RBCs and all the cells, let's see the formation of all these cells. Hemopoiesis. There are stages of the cell formation. Stages of erythropoiesis and stages of hemopoiesis. In the first trimester of pregnancy, mesoderm of the yolk sac forms the cells. From 3 to 6 months or third trimester, liver and spleen form the RBCs and the other cells. So it's called as hepatic stage. And 6 months onward, bone marrow starts forming the cells. So that's called as a myeloid stage. Bone marrow takes over and bone marrow starts forming all the cells, so that at the time of birth, bone marrow will be the sole organ producing the cells. Initially, all the bones contain red bone marrow. At birth, almost all bones have red bone marrow producing the cells, but slowly fat infiltrates the bone marrow and then it turns yellow, so that by the age of 18, only a few sites are left with the red bone marrow, which is still producing the cells. So the sites are the long bones, the proximal ends of the long bones like humerus and femur, flat bones, sternum, vertebral bodies, anterior superior iliac spine. It's important to know these sites because later on you will understand when there is bone marrow tapping or biopsy to be performed, what are the sites where you need to tap to collect the bone marrow samples. So these were the few places where red bone marrow is still left after the age of 18. Now, so far as the erythropoiesis is concerned, first of all cells are going to be formed from a common precursor, which is the pluripotent hematopoietic stem cell. It's a 24 micron diameter cell, and this cell will give rise to the colony forming units, which will eventually be forming the different cell types. So colony forming unit for erythrocyte, colony forming unit CFU mega, that's megakaryocyte, which will form the platelets, and CFU GM, granulocyte and monocyte, because at this stage lymphoid precursors, they leave the bone marrow, and there will be further differentiation in the lymphoid organs. So only granulocytes and monocytes will be formed in the bone marrow itself from this stage onwards. Lymphocytes will be processed further outside the bone marrow in the lymphoid structures, as we will see later. Right. Just one more point that needs to be highlighted here is that in the bone marrow, what is the ratio of myeloid precursors to erythroid precursors? The answer is 3:1. The myeloid to erythroid ratio will be 3:1. I mean 75% precursors will be forming the WBCs and 25% precursors will be eventually forming the RBCs. Now, how is this possible when we say RBC count is 5 to 6 million per cubic millimeter, whereas WBC count is only 4 to 11,000 per cubic millimeter? The reason is obvious. The reason is lifespan. RBC lifespan is much longer as compared to the WBC lifespan, and therefore, although the red cell precursors are less in the bone marrow, you see that RBC count in the peripheral blood is more. We will discuss about the division of these cells in detail. Now, further, they will be forming the progenitor cells and then the proerythroblast. Proerythroblast is the stage which is morphologically identifiable as RBC. I mean, at this stage, the RBC can be morphologically identified as this is going to form the RBC. Whereas these will form platelets, these will form granulocytes and monocytes. Now then, if you look at the process of erythropoiesis, two processes are going to form simultaneously. You see, these erythrocytes, precursors of the erythrocytes are nucleated, whereas the matured erythrocyte is non-nucleated. So, somewhere down the line, nucleus is going to be extruded when the erythropoiesis is happening. But the precursors have nucleus, and therefore cell division is happening and cell maturation is happening. These two processes are going to take occurring simultaneously. Now, proerythroblast will give rise to early, intermediate and late normoblast. Hemoglobin synthesis actually begins in the early normoblast stage, but it is the intermediate normoblast stage where hemoglobin begins to appear in the substantial amounts. So, hemoglobin synthesis just starts in the early normoblast stage, but hemoglobin begins to appear in the intermediate normoblast stage. As its quantity increases and it begins to appear, that would be the stage of intermediate normoblast. So, now one more fact to be noted here is that hemoglobin will be basic in nature and therefore it will attract the acidic stain. So, up to this stage, the content were acidic and therefore they were attracting the basic stain, they were basophilic. But from hemoglobin stage onwards, I mean once hemoglobin begins to appear in the cell, it will be acidophilic. The content is basic, it will attract the acidic stain, so it will be acidophilic content. Then from late normoblast stage, there is formation of reticulocyte. At this stage, the RBCs leave the bone marrow and over the next 24 hours, they matured into the matured erythrocyte in the peripheral circulation. So, the stage at which RBC leaves the bone marrow is reticulocyte stage. At this stage, nucleus, already in the late normoblast stage, the nucleus had become very small, a pycnotic nucleus or ink spot nucleus. Finally, it will be broken down and either extruded out of the cell or dissolved into a fine dust and finally disappears. So then, reticulocyte stage, the RBC will leave the bone marrow, it will come into the circulation and over the next 24 hours, it will mature into the erythrocyte. Now, reticulocyte count, normal reticulocyte count in the circulation is about 0.2 to 2%. That means of the total circulating RBCs, only about 2% will be in the reticulocyte stage. What is the importance of this? Reticulocyte count is higher in infants and children. Reticulocyte count is higher in the conditions of hypoxia. So it means that due to the hypoxic situation, the RBC production has been hastened, and therefore more and more RBCs being formed faster and released faster into the circulation. The reticulocyte percentage in the peripheral blood is higher. The erythrocyte formation, erythropoiesis, takes about 7 to 9 days. This entire erythropoiesis process takes about 7 to 9 days. Let us see the factors that influence the erythropoiesis. There are nutritional factors, iron, iron needed for formation of heme, for the hemoglobin, vitamin B12, folic acid. Now, vitamin B12 and folic acid are needed for the formation of 5,10 dimethyl tetrahydrofolate, the maturation of DNA. I mean, this is the precursor of DNA, and from which nuclear maturation will occur. So B12 and folic acid are needed for nuclear maturation in the RBC precursors, and therefore deficiency of B12 and folic acid would cause deficiency of DNA maturation, deficiency of nucleus formation, and if there is no nucleus formed properly, then there will be no cell division. As we discussed previously, there are two processes going on simultaneously: the cell division and cell maturation when the erythropoiesis is happening. Now consider this, that if the cell division does not happen because nucleus has not formed, then the cells do not divide. See, it's one factor that I'll just bring in here is that pluripotent hematopoietic stem cell was 24 micron diameter, but final RBC is about 8 microns diameter. Why? Because cell division occurs very, very rapidly, and it goes through the subsequent stages. So a parent cell divides into two daughter cells. Before they could regrow to the parent cell size, they are further divided. So cell division is rapid, and therefore through the subsequent stages in erythropoiesis, the cell size goes on decreasing, the diameter goes on decreasing. Now cell division is because of the nucleus, and therefore if there is deficient nuclear formation due to the deficiency of either B12 or folic acid, then the cell division will not occur, and therefore the cells will remain immature and large. The cells will be large and immature. That is the result. I mean, the resultant condition is megaloblastic anemia. So why the cells are large and immature? Because of this reason. And therefore vitamin B12 absorption needs intrinsic factor of Castle from the stomach. Any deficiency of intrinsic factor of Castle from the stomach would also cause vitamin B12 deficiency, resulting in megaloblastic anemia. We are talking about the nutritional factors. Other nutritional factors such as other vitamin B complex, copper, cobalt, zinc. Then the other important factors for erythropoiesis, most important being hypoxia. Hypoxia will be sensed by the renal cells, type 1 cortical interstitial cells in the kidney, and it will cause release of erythropoietin, and erythropoietin then hastens erythropoiesis. The total duration required for the process of erythropoiesis would be completed in about 5 to 6 days instead of 7 to 9 days under the influence of this erythropoietin. It acts on the first two stages, I mean conversion of pluripotent hematopoietic stem cell to the colony forming unit and colony forming unit to proerythroblast. The first two stages are made very rapid under the influence of erythropoietin, and overall process of erythropoiesis is also hastened by erythropoietin. Next, hormonal factors that influence erythropoiesis. Now, testosterone is known to stimulate erythropoiesis. How? Testosterone stimulates erythropoiesis in 3 ways. 1, it goes to the kidneys and increases the secretion of erythropoietin. 2, it goes to the bone marrow and increases the receptors of erythropoietin receptors EP1 and EP2. So, upregulation of erythropoietin receptors in the bone marrow by testosterone. And third, in some unknown way, it directly stimulates the erythropoiesis. So, testosterone, a stimulator of erythropoiesis, whereas estrogen is known to suppress the erythropoiesis. And that's the reason why males have a higher RBC count compared to females. The normal RBC count, males 5 to 6 million per cubic millimeter, females 4.5 to 5.5 million per cubic millimeter. The reason males have higher RBC count is this. So these were the factors influencing erythropoiesis. Let us discuss the WBCs. Basically, the WBCs, you know, they are involved in the defense mechanisms. WBCs are of 2 types, the granulocytes and the agranulocytes. The granulocytes, they have granules, and depending on what type of stain those granules take up, there are 3 types: the neutrophils, eosinophils, basophils. Agranulocytes, monocytes and lymphocytes. If you see the relative percentages, most populous is neutrophils, 50 to 70%, followed by lymphocytes, 20 to 30%, then monocytes, 2 to 8%, eosinophils, 1 to 4%, and basophils, 0 to 1%. Now these are the percentages of these cells. Apart from this, there is something called as absolute counts of these cells. You see, we count 100 WBCs, and if one cell is increased, then there would be decrease in the other count, because we are counting only 100 WBCs. So, if one cell has increased, there would be a relative decrease in the number of other cells. Therefore, to avoid misjudging this, whether one cell has increased and other cell actually has decreased or it's a relative decrease, we also take absolute counts of these cells apart from these relative percentages. So what we actually calculate is, first the TLC is done, total leukocyte count, and then the differential leukocyte count is done, From the TLC, let's say TLC is 10,000 per cubic millimeter and we get the neutrophil 50%. So the absolute neutrophil count would be 5,000 per cubic millimeter. Whatever percentages we get on each cell, absolute counts are calculated from our total leukocyte count. And then we have a certain range, so we know whether the cell has actually decreased or it's within the range. That's the reason for calculation of absolute counts. Now, talking about the WBCs, let's see the WBCs one by one. Neutrophil, the most populous cell, 50 to 70%. Now, in the case of neutrophil, there is an Rneth count. Rneth count of the neutrophils. What is that? You see, when a neutrophil is formed in the bone marrow, it has got one lobe, but as the neutrophil grows mature, the number of lobes go on increasing. So, based on the number of lobes of neutrophil, this Rneth count is devised. So, we have 5 stages in the neutrophil. Stage 1 means single lobe nucleus. About 5% cells in the peripheral circulation will be stage 1. This is the count of neutrophils. Stage 2, 2 lobes in the nucleus. About 15% neutrophils will be stage 2. Stage 3, 35 to 45%. So maximum neutrophils in the circulation would be stage 3. Stage 4, 10 to 15%, and stage 5, 5 lobes in the nucleus, 5%. So a bell-shaped curve can be obtained for the Rneth count. These are the percentages of neutrophils, and stage 1, stage 2, 3, 4 and 5. And that's the curve. So, shift to left would indicate what? If the curve is shifted to the left, it will mean there are more neutrophils which are younger with single or 2 lobes, and that indicates a sign of infection, because neutrophil is a first line defense, and in the conditions of infection, neutrophil is going to be formed rapidly, and it's going to reaching that site rapidly, and therefore more formation of neutrophils in the bone marrow is indicated by this shift to the left, whereas shift to the right means older neutrophils in the circulation. That means formation of neutrophils has slowed down. It would be a bone marrow depression. So that's Rneth count. There is a similar count which is called as Schilling's index. This has only 4 stages instead of 5. Well, that's about the neutrophil. Lifespan of neutrophil is very less, about 4 to 6 hours in the circulation, and then next 4 to 5 days in the tissues. Most of the WBCs have a very short lifespan, except 2, the lymphocytes and monocytes. Lymphocyte has the longest lifespan. Let's just enumerate it here since we have talked about the lifespan. Lymphocyte has got a lifespan of 300 days. So longest lifespan among the blood cells would that be of lymphocyte. Now I'm not counting macrophages here. You see, monocytes are there for a few hours to few days in the circulation, and then when they go into the tissues they become macrophages, and in the tissues they convert into macrophage and remain in the tissue for a few months. So I'm not counting that. Otherwise, monocytes in the circulation have got a less lifespan. RBCs, of course, lifespan of 120 days. What is the lifespan of stored RBCs? What is the half-life of stored RBCs? So lifespan of stored RBCs is about 60 days, and half-life of the stored RBCs, when the blood is stored, there the lifespan is about 28 to 32 days, half-life of the stored RBCs. Then the other cells, their lifespans. Neutrophils, I have already mentioned. The lifespan of neutrophils, 4 to 8 hours, 4 to 8 hours in the circulation, and next 4 to 5 days in the tissues. The other cells, eosinophils, basophils, also have shorter lifespans compared to these cells. Well, platelets, since we are just talking about the lifespan, let me just compare it here. The platelets have got a lifespan of 8 to 12 days. Half-life of a platelet is 4 days, and half-life of a stored or transfused platelet is only about 1 day or even less, because platelets lose their survivability very rapidly when they are stored. So half-life of a stored platelet is even less than a day. These are the lifespans of various blood cells. We were talking about the WBCs. So first line defense, we've already seen the neutrophil. Second line defense is monocyte. The second line defense is monocyte. This is the largest WBC. 18 to 24 micron diameter. This is the largest WBC. And like neutrophil, even monocyte is involved in phagocytosis, particularly of larger type of microorganisms. You know, neutrophil count increases in acute febrile illnesses, any infectious conditions, fevers. When is it that we see monocytosis? Monocyte count increases when there are larger bacteria involved, larger parasites involved. For instance, malaria. In malarial fevers, you see monocytosis because malaria is a large parasite. It has got erythrocytic stage. It's one of the life stages in the life cycle is inside the RBC. So monocytes can engulf and phagocytose that parasite or even that RBC which has that parasite. So that's how you see monocyte count increased in malaria. Then the other cells, the third line defense is lymphocyte. Lymphocyte is said to be the third line defense. And the lymphocyte is the basis for our immunity. Our immune system, our immune mechanism, immunity is based on the lymphocyte. Basically two types, T lymphocyte and B lymphocyte. Now very often this confusion stays with the students that morphologically you see small lymphocyte and large lymphocyte, and functionally you see T lymphocyte and B lymphocyte. Is there any connection? There is no such connection that small is T and large is B or something like that. Morphologically, we see two types of lymphocytes. The smaller lymphocyte is a more matured lymphocyte. Lymphocyte, it grows large and then divides into two small lymphocytes. So you see small lymphocytes, it's a more matured lymphocyte. That's morphological classification. Whereas this is the functional classification. T stands for thymus. thymus dependent lymphocytes, when the lymphocyte is pre-processed in the thymus. And B stands for bursa of Fabricius. Basically this bursa of Fabricius is found in the lymphoid tissue of the intestines in birds and chicken, but there is no such bursa found in the humans. Bursa equivalent in the humans is the bone marrow, so we can consider that B as the bone marrow. T lymphocyte is involved in the cellular immunity or cell mediated immunity, because the entire cell would react with the foreign antigen, whereas B lymphocyte is involved in the humoral immunity, because B lymphocyte does not react by itself. B lymphocyte forms an intermediary called as plasma cell, and this plasma cell forms secretes the antibodies. I mean, B lymphocyte forms the antibodies, but when it needs to secrete those antibodies, it will first form the plasma cell, and then will be continuous secretion of antibodies, the immunoglobulins, and those immunoglobulins would react with the antigens. So this is called as humoral immunity. 5 types of antibodies: IgG, IgA, IgM, IgD, and IgE. There was one question very repeatedly asked: which of the following is the secretory antibody? Answer was IgA. IgA antibody is a secretory antibody. So each of these antibodies have their specific roles to play in the immunity. That's the lymphocyte. Next, WBC is eosinophils, about 1 to 4% in the circulation. Eosinophil count is known to increase in 2 conditions: the parasitic infestations. Now, why it increases in these parasitic infestations or worm infestations is because eosinophils known to have, their granules have a protein called as major basic protein. This major basic protein is known to immobilize the parasites, and then they can be killed or expelled out of the body. And for this reason, eosinophil count is known to increase in parasitic infestations. And the second condition is the allergies. In allergic conditions, you see the eosinophil count has increased. Next, basophils, only about 0 to 1%. They synthesize and secrete heparin and histamine. Even basophil count is known to increase. It's not common to have increased basophil count. Increased basophil count is called as basophilia, by the way, but it needs to be differentiated between the basophilia and the punctate basophilia. You see, allergic conditions will have increased basophil count, but and that would be called as basophilia. But what is punctate basophilia? There are certain conditions, for example, lead poisoning. In this condition, the RBC maturation is arrested and there is basophilic stippling of the RBCs. We have seen this in the erythropoiesis, that the first few precursors of the RBCs, they are basophilic, they have acidic content, and therefore they attract basic stain, they are basophilic. And only when the hemoglobin appears, hemoglobin is basic in nature, it will start attracting the acidic stain. But if the maturation is arrested in the first few stages during erythropoiesis, then there is the resultant condition is the punctate basophilia seen in the lead poisoning. So that's a basophilia seen in the lead poisoning, but that's a condition of RBCs, basophilic stippling of RBCs or punctate basophilia, and this basophil is increasing the basophil count. So these are the WBCs, various WBCs with their functions. Let's see the third cell and the phenomenon associated with it. The third cell is platelets, also called as thrombocytes. It's formed in the bone marrow from, as we've seen, colony forming unit for megakaryocyte. So platelets are formed from megakaryocyte. One megakaryocyte can form somewhere between 1000 to 4000 platelets. Platelets just simply detached, they are pinched away from the megakaryocyte and they form the platelets. Normal platelet size is about 2 to 4 micron diameter. Platelets are non-motile, non-nucleated cells. Normal platelet count is 1.5 to 3 lakhs per cubic millimeter. However, there is something called as critical platelet count. Now, critical platelet count, if the platelet count falls below 40,000 per cubic millimeter, then the arrest of bleeding will become very, very difficult. So therefore, this count has been called as critical platelet count. There is a difference of opinion in this. Some pathologists call it 20,000, some pathologists call it 40,000, but universally accepted as 40,000 per cubic millimeter is called as critical platelet count. Below this, the bleeding, stoppage of bleeding would be difficult. Platelets basically have a few components such as canaliculi, open canaliculi. This is for the entry of calcium. And this calcium is needed for what? This calcium is needed for various processes. Platelets have dense granules and dense bodies. These granules are going to release certain chemicals. ADP, thromboxane A2. When the platelet is activated, calcium will enter the platelet, and this calcium will cause exocytosis of these granules. ADP, thromboxane A2 will be released so that more and more platelets are taken into that area and they adhere to the previous platelets, forming a platelet plug. So that's the function of the platelet. Basically, after the injury to the vessel, stoppage of bleeding is the function of the platelet. Apart from this, this calcium is also required for the contractile filaments. There are certain contractile filaments in the platelets. Now, the contractile filaments like actin, myosin and thrombostatin. What is the function of these contractile filaments? You see, once the platelet plug is formed and the bleeding has been stopped, on the surface of the platelet plug, the clot forms. But then this clot needs to be retracted. These injured vessels need to be pulled towards each other so that the vessel healing starts. Vessel will heal, this ruptured vessel, and the clot reduced in size, retracted. These are the functions performed by these contractile filaments. Once the platelet plug has been formed, these contractile filaments inside the platelets, they will contract, and that will pull the injured edges of the blood vessel towards each other for the sake of healing, and clot retraction also would happen. So that's platelet and its summary. The deficiency of platelet leads to the condition called as purpura, the thrombocytopenic purpura. Deficiency of platelets is thrombocytopenia, and the commonly known condition is ITP, idiopathic thrombocytopenic purpura. Now what happens is, because of the deficiency of platelets, there is bleeding into the skin and purple patches appear in the skin, for which reason this has been called as purpura. Now, another point that is also should be known is platelets, they stop the bleeding. Then why do we need the clot formation? So that takes us to the topic of clot formation now. You see, platelets have arrested the bleeding in about 1 to 3 minutes. The normal bleeding time is about 1 to 3 minutes. Now, clot formation occurs in about 4 to 9 minutes. That means after the bleeding has been stopped, clot is forming. Why clot formation is necessary? For 2 reasons. So let's differentiate between the platelet plug formation and the clot formation, their functions, their roles. First of all, small injuries which we encounter in a day-to-day routine, they are only filled by platelet plug. There is no clot formation there. If there was clot formation everywhere in every small injury, then all the circulation will be filled with clots. So therefore, smaller injuries are filled only with platelet plug, and only bigger, larger injuries to the vessels is where clot formation is necessary or clot formation occurs. That's the first point. And second is, platelet plug is a temporary phenomenon. I mean, it can get dislodged and again the bleeding will occur. So there should be the time allowed for the vessel to heal, and that time is given by the clot. Clot will stabilize this platelet plug and it will allow for the healing to occur. These injured edges can come towards each other, the healing can occur. So therefore, that's the significance of clot formation even after the bleeding has been stopped. Now coming to the clot formation, basically clot formation occurs in 3 essential steps. First is conversion of prothrombin. Prothrombin is a plasma protein, it's already there in the plasma, to thrombin. Then thrombin acts enzymatically on fibrinogen to convert it into fibrin monomers, and then polymerization of the fibrin with cells getting enmeshed. That's the clot formation. So 3 essential steps in which the clot formation occurs. But the rate limiting step in the formation of clot is formation of prothrombin activator. That's the rate limiting step. And this prothrombin activator, it's not there in the plasma, it's going to be formed. Prothrombin activator is formed in 2 ways. One is when there is tissue injury and there is release of tissue thromboplastin. And this forms finally the prothrombin activator. This is called as extrinsic mechanism of clotting or extrinsic pathway of clotting. Whereas if there is trauma to the blood itself or factor 12 in the blood comes in contact with the glass, water wettable surface, or it comes in contact with subendothelial collagen, and that initiates the clotting process, then it's called as intrinsic pathway for clotting. The reason is intrinsic to the blood. Factor 12 gets activated and that initiates the formation of prothrombin activator. That's intrinsic pathway for clotting. So let's just quickly also go through these clotting factors. Roman numerals were given to these clotting factors. International Committee for Standardization in Hematology, the ICSH, it gave these Roman numbers. So factor 1, fibrinogen, factor 2, prothrombin, factor 3, tissue thromboplastin, factor 4, calcium. Please make a note of this, that each step in the clotting process needs calcium. Except for the first two steps in intrinsic pathway, all other steps need calcium. Factor 5, labile factor. Factor 7, stable factor. They had found out the factor 6, but then it was seen that this factor 6 is very labile. It immediately gets converted to factor 7, and therefore its separate existence was denied later on. But by that time, next and next factors were discovered, and therefore they did not change those numberings. Factor 5, factor 7, factor 8, anti-hemophilic factor or anti-hemophilic globulin, factor 9, Christmas factor, factor 10, Stuart-Prower factor, factor 11, plasma thromboplastin antecedent, factor 12, Hajman factor, and then factor 13, 14, such as high molecular weight kininogen and prekallikrein. These are the clotting factors, and as we have discussed, they interact, they are enzymatically activated to form the next factor, or next factor is enzymatically activated, then it acts enzymatically on the next factor to activate it, and so on. So it has been called as enzyme cascade hypothesis or waterfall sequence theory. For instance, in intrinsic pathway of coagulation, factor 12, it gets activated when it comes in contact with a water wettable surface like glass, or it comes in contact with subendothelial collagen. It will act on factor 11 to convert it into 11A. Then that will convert 9 to 9A. So each factor, once it is activated, it acts enzymatically on the next factor to activate it. Factor 9 in the presence of factor 8 and calcium will convert factor 10 to 10A, which is the prothrombin activator, and then the subsequent steps will follow. That's intrinsic mechanism. Whereas extrinsic mechanism, as we have said, tissue trauma, release of tissue thromboplastin, and that will form the factor, convert 10 to 10A in the presence of factor 5 and factor 7. So that's the mechanism for coagulation or pathways for coagulation and the clotting factors. Let's quickly see the anticoagulant mechanisms. Anticoagulant mechanisms in vitro and in vivo. First of all, let's see the anticoagulants outside the body. What are the factors that would prevent the clotting? For example, dilution of blood by more than 20 times will retard the clotting process, because then the clotting factor will not be able to come together to form the clot, and the clotting will be prevented. The other in vitro anticoagulants, heparin can be used as an in vitro anticoagulant. Heparin can be used in vitro or in vivo. How does heparin act as an anticoagulant? Heparin acting via antithrombin 3 prevents the clotting of blood, and that's a very important anticoagulant. Apart from this, the citrates, oxalates, EDTA, you see, each one of them have a certain importance. They are used for certain purpose. For example, citrates, oxalates, EDTA are used for either a collection of blood samples and storage of blood, or storage of blood samples, or either for blood testing, or large samples of blood for transfusion of blood. How do they act? They act by chelation of calcium. Calcium is chelated in the blood. As we have seen, calcium is needed for each stage of each step in coagulation. So these factors chelate the calcium. Calcium is not available, and clotting will not occur. In vivo anticoagulants, well, there are certain anticoagulant mechanisms. For example, smoothness of the endothelium. It prevents the clotting factors to come together and cause the clot to occur. A layer of glycocalyx on the endothelium, it repels the clotting factors and does not allow the clotting factors to come together and form the clot. So a layer of thrombomodulin on the endothelial cells, that prevents the clotting. So some of the natural anticoagulants present in the body. Heparin, as we have already said, heparin is a natural naturally present in the body, as well as a synthetic heparin is used. So let me just say one line about it. By activation of antithrombin 3, heparin acts as an anticoagulant. In vitro, heparin is used to heparinize the patient after myocardial infarction or cerebral infarction. The patient has a tendency to form the clots, and therefore the patient is heparinized. So that's the use of heparin in the hospitals. Here we are talking heparin that's formed in the body. In vivo, it's anticoagulant, and heparinized patients, the in vitro use of the anticoagulants. Tissue plasminogen activators. Streptokinase, urokinase, they convert plasminogen to plasmin. The plasmin has trypsin-like activity, digestive activity, proteolytic enzyme-like activity. So this will digest the fibrin threads, and the clot will be digested. So another anti-clotting mechanism in the form of tissue plasminogen activators. In fact, streptokinase is a very critical component of treatment in MI. The golden period in MI, the first hour or first few hours, the golden period where the myocardium has to be saved, that time this streptokinase is administered. It will digest the fibrin fibers, break down the clot, and restore the blood flow to the myocardium. So these are some of the anticoagulants or anticoagulant mechanisms. Let's now talk about the blood groups. What are blood groups? Basically, population is divided based on presence or absence of certain antigens. So there are 20 blood group systems have been discovered so far. For example, ABO, RH, Kell, Duffy, Lewis, Lutheran, so many of them. Each one of them has some limited significance. For example, there is one M and N blood group system. It is said to be used for or can be used for paternity disputes. This by exclusion, the biological parent of the father can be determined. So each of these have their own limited purpose. Clinically speaking, we have only two important blood group systems, ABO and RH. So let's discuss these ABO and RH blood group systems. The ABO system has these two antigens, A and B antigens. Now, therefore, there are four blood groups: A, B, AB, and O. Carl Landsteiner discovered these blood groups, and he called O as universal donor because O does not have any antigen, and AB as universal recipient because AB has no antibodies in the plasma. So Landsteiner's law, when a particular antigen is present on the RBCs of the individual, then the corresponding antibody will not be present in the plasma of that individual. So A will not have anti-A in the plasma, but that person will have anti-B in the plasma. B will have anti-A in the plasma. AB, both antigens are present, so no antibodies in the plasma, and O, no antigen present, so both anti-A and anti-B antibodies in the plasma. Now, apart from this, there is also one more very rare group called as Bombay blood group. Bombay blood group is written as O small h. This blood group is O, but it's not a normal O. So let me just say what's this normal O mean, what I meant by normal O. You see, our normal ABO blood group system has two antigens, or rather two genes, A and B, and there's an independent gene called as H gene. H gene forms H gene product or H substance. That's a certainty in most of the individuals. H gene is dominant and it forms H substance. Now somebody has got a gene dominant, he will form H substance, and that H substance will act via H substance to form A antigen on the RBCs. The blood group will be A. If the B gene is dominant, then B substance will be formed, and then via H substance it will form B antigen. The blood group will be B. If both A and B are dominant, then both antigens will be formed. Blood group will be AB. And if A or B, both genes are recessive, then the blood group is O. But that's O blood group, normal O blood group. What is Bombay blood group is H gene itself is recessive. So in such a person, whether A or B gene is dominant will not matter, because there is no formation of H product. H gene is recessive. No formation of H product. So whether A substance or B substance is formed is irrelevant, because A and B antigens cannot be formed in this person because H substance is not there. H gene is recessive, and therefore the blood group will be O, but that O is because of H gene recessive. What's the significance? The significance is this person has 3 antibodies in the plasma: anti-A, anti-B, and anti-H. So this person can be safely transfused with another Bombay blood group only. So that's the significance of this very rare group, the Bombay blood group. Then came, almost 40 years later, came the discovery of RH blood group. RH blood group is based on the antigens, which are of 6 types: capital C, small c, capital D, small d, capital E, small e. Most of the times, 95% of the times, it's the capital D antigen. So RH is synonymous with D antigen. If it's present on the red cells, you call it RH positive. It's not present, you call it RH negative. Now talking about anti-RH antibody. It is not present in any of the individuals, whether RH positive or RH negative. Let me explain what I am saying. Look at the ABO blood group system. In A blood group person, there was anti-B antibody. In the B blood group person, there was anti-A antibody. So anti-A and anti-B antibodies are seen naturally. They are naturally occurring antibodies. Anti-RH antibody is not a naturally occurring antibody. It's neither seen in RH positive. 85% to 90% population is RH positive. So RH antigen is self for them, and anti-RH antibody will not be formed. And 15% population is RH negative. For them, they have never got exposed to the RH antigen, so they will not have anti-RH antibody. So the only person who will have anti-RH antibody is RH negative person who has received RH positive blood. Only such a person will have anti-RH antibody. If I have to explain it further, what about these what about these, just make a correction, A blood group has anti-B antibodies, B blood group has anti-A antibodies. What about these anti-A and anti-B antibodies? From where they have come in the plasma? You see, A and B substances, they are not only present on the red cells, they are present in other tissues of the body also, these A and B antigens. They are present in the nature also. So, when a child is born, and suppose the child's blood group is A, in subsequent days after the birth, the child gets exposed to both A and B antigens from the nature, through food, through bacteria. So when both A and B antigens will enter the body, person's blood group is A, so A will be recognized as self, and antibody will not be formed against that A antigen coming from outside. But B will be recognized as foreign by this A blood group individual, and against that the antibody B will be formed in the plasma. This is the reason why anti-A and anti-B are seen naturally in the plasma, because these A and B antigens occur in the nature also outside the body, and the person gets exposed to those antigens from outside, whereas RH antigen is present only and only on the red cells. So anti-RH antibody will be seen only in one circumstance, when RH negative person receives RH positive blood. So the person is getting exposed to that antigen, the person will form the antibody. That's the RH blood group system, and incompatibility between mother and fetus about the RH blood group will result in what is called as hemolytic disease of the newborn or erythroblastosis fetalis. So mother RH negative, and she conceives the baby with RH positive blood. Now during the pregnancy, there would not be much of an effect, but during parturition or during some obstetric manipulation, there would be a feto-maternal bleed, and some amount of fetal Rh antigen is likely to enter the mother's circulation. We have assumed here that the mother was never previously exposed to the Rh positive blood. Now she is getting exposed to it for the first time, the Rh antigen. Baby is delivered, but the mother is getting exposed to the Rh antigen. So within next 48 to 72 hours, she will start forming the anti-Rh antibodies. Now, next 2 to 4 months, the Rh antibodies will have been formed in her body. Now, if she conceives again for the second time and again the fetus is Rh positive, then these antibodies, anti-Rh antibodies formed in the mother's body, will now be transferred to the fetus via placenta. Look, placenta was a barrier for the antigen. Fetal antigen could not cross the placenta and go to the mother's circulation. But antibodies can cross the placenta because these are IgG type of antibodies. They can cross over from the mother to the fetus. I'm talking about the second child. These are IgG antibodies, and in the fetus, particularly this antibody titer will go on increasing after 34 to 36 weeks of gestation. So there would be antigen and antibody reaction in the fetus. It will result in destruction of RBCs, therefore anemia, jaundice, because RBC destroyed, hemoglobin liberated and converted into bilirubin. So anemia, jaundice, acute renal shutdown, these are some of the common manifestations of excessive massive hemolysis. So how do you treat them? How do you treat the erythroblastosis fetalis? Either it can be prevented, or first of all, preventive measure would be after the first delivery, when mother has received that Rh antigen, she should be injected with anti-D serum. Anti-D serum, the serum that contains anti-Rh antibodies or anti-D antibodies. So before this Rh antigen, which has entered the mother's circulation, before it could sensitize the mother's immune apparatus and mother's immune system starts forming the antibodies, this anti-D serum will coat that antigen and will destroy that antigen. So mother's immune system will not get exposed to, she will not be sensitized by those Rh antigen coming from the fetus. That's a preventive measure. But if it could not be taken, if it could not be done, then treatment of erythroblastosis fetalis. Look, there would be massive RBC breakdown in the fetus, and therefore, as a reaction, more and more immature RBCs, they come into the circulation, for which reason this is called as erythroblastosis fetalis. Blast is an immature RBC. So anemia and jaundice will have to be treated. Exchange transfusion for anemia, phototherapy for jaundice, some of the measures. If you could not prevent the erythroblastosis fetalis. That was about some important aspects of blood groups. Finally, some blood investigations. Let's see the blood indices. Importance of blood indices in the diagnosis of anemias. PCV, commonly called as hematocrit, 38 to 45%. It's the volume of the red cells. You know, any unit quantity of blood will have 38 to 45% cells and 55% plasma. It will decrease in anemia. It will increase in polycythemia. Second, MCV, mean corpuscular volume. On an average, what is the volume of one single RBC? 78 to 93 cubic microns. That's average volume of one single RBC. How do you calculate it? You take the sample of blood, perform PCV on it, perform RBC count on it, and PCV upon RBC count. See, it's very simple to understand. These many RBCs have this much packed volume, this much volume. Then one RBC will have how much volume on an average? That's the mean corpuscular volume. Normal value is this, 78 to 93 cubic micron, 94 cubic microns. If it is less than 78, you call it microcytic anemia. It's called as microcytic anemia. The cell size has reduced. Common cause is iron deficiency. And if it is more than 94 cubic microns, then it is called as macrocytic anemia. Macrocytic anemia, cell size has increased. So, megaloblastic anemia. As we already discussed this, vitamin B12 and folic acid deficiency, cells, the nuclear maturation is deficient and therefore cells cannot divide, they remain large and immature. It's the macrocytic anemia. The third blood index is MCH, mean corpuscular hemoglobin. How it's calculated? On an average, how much hemoglobin is present in one RBC? That's mean corpuscular hemoglobin. The normal value is about 28 to 32 picograms, I beg your pardon, 28 to 32 picograms or micrograms. How is it calculated? HB upon RBC count, mean corpuscular hemoglobin. Take a blood sample, take the RBC count of that sample and hemoglobin estimation. Then these many RBCs have this much hemoglobin, then one RBC will have how much? That's the mean corpuscular hemoglobin. In the iron deficiency anemia, even this would be decreased. The third one is MCHC. The next one is MCHC, mean corpuscular hemoglobin concentration. Now this is different from MCH. Let's see how. Mean corpuscular hemoglobin concentration is about 32 to 38%. Means how much part of the RBC is saturated with hemoglobin. That's mean corpuscular hemoglobin concentration. On an average, how much is the saturation of one single RBC? So, almost 38% of the RBC volume is saturated with hemoglobin. What is the significance of this? You see, consider this. If the MCH is normal, but if the MCHC has reduced, what will be your inference? If the mean corpuscular hemoglobin is normal, that means your hemoglobin level is normal, or on an average in one RBC how much hemoglobin should be there, that is normal. But MCHC has reduced. That means what? That means RBC size has increased. So, a normal amount of hemoglobin, but because RBC size has increased, it occupies less volume or it saturates less of the, this is just a diagrammatic representation. So, MCH normal but MCHC has reduced means macrocytic anemia, megaloblastic anemia, RBC size has increased. And the last one of the color index, last one of the blood index is the color index. Color index is hemoglobin percent upon RBC percent. Now what does it mean? You see, 14.5 grams percent of hemoglobin is taken to be 100%. And RBC count 5 million per cubic millimeter is taken to be 100%. These are the standards. And then patient's hemoglobin is checked against that, and then you take the hemoglobin percent and RBC percent. For example, 5 million RBCs is considered to be 100%, and if the person's hemoglobin is person's RBC count is 4 million per cubic millimeter, that means the RBC is 80%. So in this manner you take hemoglobin percent and RBC percent and derive the color index. Normal value is about 0.8 to 1. And if it is less than 0.8, we call it hypochromic anemia. And if the anemia with color index between 0.8 to 1, we call it normochromic anemia. So color of the RBC because of its hemoglobin, and based on that, this calculation called as color index. So these were some of the aspects of blood or hematology normally discussed in physiology.